I would thank you for your waiting and sorry about the technical problem. The topic I'm talking about is the contemporary strategy in AFib management. What I'm focusing on is the early antiarrhythmic drug or early case separation, and maybe the better or best will be early revision control or in AFib management. And this is the sign that we usually see when seeing the patient in the clinic. We see this is slide showing the atrial fibrillation, and we will say that a patient will ask you what you're going to do with it. And sometimes the patient with the technical advance in recent years, they get a smartphone, they can also have the patch or the chest band or some rings to show you some needs about atrial fibrillation. So that's a question when you come into patient come into your clinic. Normally you electrophysiologist or not. So for this patient, first question coming to you would be that is this in this first time no atrial fibrillation, is this really an early atrial fibrillation? Or maybe next question is coming to you is this first time no atrial fibrillation is really a kind of a paroxysmal atrial fibrillation, or is it actually only part of the persistent atrial fibrillation, or even a permanent part atrial fibrillation? With different type of atrial fibrillation, what should we do with this atrial fibrillation? As a clinical cardiologist, we should think about all these questions. But first of all, about the management of this patient, we have the problem that we have the only unstable fibrillation in the first place. We classify them by the duration, usually less than 40 hours for paroxysmal, more than 1 week, or require cardiovascular and call it persistent, even longer time to 1 year quite long standing. And sometimes you cannot do anything about it, even by cardiovascular, we call it permanent. But this is a quite arbitrary method to classify the atrial fibrillation. By this method recall, we can see that by a more detailed recording of atrial fibrillation for longer time by either loop recorder or the CIED, the pacemaker recording, we notice that the so-called atrial fibrillation actually is not very easy to differentiate. Take the right side figure, you said that the red color means the identified as persistent atrial fibrillation, and the blue side is called paroxysmal atrial fibrillation. For this patient, you can see that even with very high atrial fibrillation burden, that means the total time the atrial fibrillation has been occupied during the observation period. You can see that it could be still very long in atrial fibrillation, but you still call it paroxysmal or not really calling it persistent. That means that we don't really know how much of the time the patient in atrial fibrillation. And this is a very important question because we know that for all the infinite device reporting, we notice that we have more the time spent in the atrial fibrillation. That means the atrial fibrillation burden, where you want less than 0 time in per day, or less than 5%, or 5 to 98% a day, you may see that the difference of the all-cause mortality, all-cause hospitalization, ischemic stroke, or cardiovascular hospitalization is all increased very steadily. And you will count it like each episode in this less than 1 hour, or 1 hour to 24 hours, or more than 24 hours, it's all showing the same thing. That means that more the time the patient stay in atrial fibrillation, the patient with more comorbidities or in the bad outcome in the long run, including all-cause mortality, cardiovascular mortality, or cardiovascular hospitalization, ischemic stroke. And this situation can be even worse when looking at the patient. You may have the patient of the hypertension, age more than 75, TIA or stroke or COPD or heart failure, so-called HUSH score. You can see that each patient with higher the score, you can have patient that will go into more prolonged atrial fibrillation. And during the progress of atrial fibrillation, that's very common in those patients with paroxysmal atrial fibrillation. You can see that during the operation, the rate of the during the operation, you can see that the patient can have more events of side effect, because ischemic stroke, major bleeding, all-cause mortality, or hospitalization for heart failure, the incidence all increased. So atrial fibrillation itself is kind of progressive problem, and you cannot really tell it from your first time ECG. When facing this patient, when at the clinic, all we can do for the cardiology is first we may think of maybe we can try anti-arrhythmic drugs. Or for the all experience, we noticed that the drugs we use for the atrial fibrillation region control, they are amiodarone, sotalol, or cross-1C freckinide mainly. You can see that they are causing more problem in all kinds of cardiovascular hospitalization or cardiovascular deaths, as affirmed show us. And further on, we have more technique on the CAS ablation. We focus on the arrhythmogenic over focus, or even the substrate in the in posterior. You can see that actually it's the way we are doing the CAS ablation, either by radial CAS ablation or by prior ablation, or even the more modern house field ablation. This is the technique we are going to use for the removal trigger and the substrate. But the initial result from the clinical follow-up atrial recurrence actually is not very good. So that's meaning that you have CAS separation as reported previously by Carl Cook or by Gears group. They also group they show only that the first year maybe you have 70%, 80% of atrial fibrillation free, but after second year it may drop to 50 or 60%. The third year it may drop to 20 to 30% that can be free of atrial fibrillation recurrence. So that's causing the problem. So in the beginning time, we always thinking that maybe this patient, when you first this patient, we will just start with the upstream therapy to treat their concomitant comorbidities, and they can start the anticoagulation if the sharp score is high, and they will start the control rate first. So the rate first control actually in the initial therapeutic decision scenario that we are using in the beginning. And then later on, we see if that control is still paroxysmal, we try anti drug or even CAS ablation. But even going to the persistent, then the role of the drug may be increased, but still we put everything on rate control as the first decision-making for clinical practice. That's the situation before the EASF-4 study. And this the time when we're coming up with the EASF-4 study. I think it's a very important paradigm-related study. It's showing that the early reason control for atrial fibrillation will really reduce the long-term cardiovascular event as a hard endpoints. So in this study, they separate all the patients with AFib less than 1 year as noted from their clinical history. They separate one group with recent control, the other group with usual care. Usually they use rate control by digoxin, by beta blocker, or by non-hydroxyphene beta calcium blocker. For the recent control, they use the propanolol, freckinide, and amiodarone as dronedarone for the control. The most popular one they use actually is freckinide, and second coming with amiodarone and also dronedarone. And this is the initially started. That's a study that has been going on for a long time, nearly 7 years. So in this period, you can see that they use these medication to reason control the patient or just simply by rate control. And they show very important result. It can show that the first primary outcome, including those deaths from cardiovascular cause, stroke, hospitalization for worsening heart failure, or hospitalization for acute coronary syndrome, altogether called the first primary outcome. This outcome is actually reduced after 7 years of observation. This is the very first study showing that you have the reason control, you can have good, really cardiovascular outcome for patient atrial fibrillation. And this is the second outcome found in the only quality parameter SF or 12 or EQ5D. They all show the same improvement. So these patients, they do improve in quality of life and also the heart outcome of the cardiovascular disease. This figure shows simply they show After 7 years of observation, early rhythm control policy indeed improved efficacious. And the sub-analysis patients found that those patients with high CHAVA score, that means the high comorbidity burden, they can benefit better from the early rhythm control. And also interesting, they also showing that patients with nearly no symptom or very mild symptom, they are also take a very good, very similar outcome improvement as those with moderate or severe symptomatic patients. So that means with or without symptom, your atrial fibrillation is coming very early within 1 year with good rhythm control vessel, mostly by anti-arrhythmic drug and very few by cath ablation. They can achieve this result. Almost at the same time, we have another Cabana study. This study, they also testing the effect of the cath ablation on the anti-arrhythmic policy for these patients early atrial fibrillation. They test on the quality, the mortality, stroke, and the bleeding, and all the cardiac arrest. In this study, for about 5 years, they can show that no difference between the two groups. I mean, the drug therapy and cath ablation, they have the same benefit or same outcome as with each other. And this result, interestingly, with the quite more comprehensive ECG monitoring data, they can see that those patients with sensitive, you can see that both the drug group and the drug group and those ablation group, they also reduction the cardiovascular atrial fibrillation burden. And for those with a persistent effect, they can also show the difference. And the difference seems that the head drug, the bupa, you can see that with this drug, even in persistent effect, you have nearly half the instant atrial fibrillation burden. And for partial smart part, it's also very effective. So that means that something is the inside of it, even you did not show the difference between the two methods to control the atrial fibrillation. And in the group, the quality analysis, you can see that with less the atrial fibrillation burden, you can see that the cath ablation is actually doing much better than drug. And this is the analysis test showing that with a more prolonged recorded by loop recorder in patients with shock-resistant persistent fibrillation. That means these patients are difficult to be converted even by cardiovascular conversion as close to the permanent group. And this kind of group, they show it by atrial fibrillation. It can also show that up to 3 to 6 months, 6 to 9 months, or up to 1 year, you can see that atrial fibrillation burden reduced significantly, and the quality of life is improved. So even with very resistant, looks very persistent atrial fibrillation, you can have a good cath ablation to isolate simply the pulmonary vein orifice. You can have the result. And this detail shows that those patients with good outcome, you can show that they don't see any atrial fibrillation burden. They call it atrial characteristic burden in those affected group. Even those with less affected group, they also show quite great reduction in the atrial fibrillation burden. And so the Bayesian plot is show that the reduction of the atrial fibrillation burden founded by the loop recorder. As a most accurate time, you can get over this. For this study, we can learn from this study, we can notice that with a rhythm control approach for these patients with atrial fibrillation, normally seen in the clinic, it's paroxysmal, persistent, or maybe even some permanent cases. You still have to work very hard on rhythm control. And rhythm control, you can really by the drug, they can control all the triggers and all the substrates, and even moderate the autonomic system, like in cath ablation. The method of cath ablation of anti-arrhythmic drug, it actually reduce the atrial trigger and also re-entry circuit and slow down the atrial progression. And the effect is really showing us that you should go more actively to rhythm control, not just very conservative rate control for these patients. So taking it from the ACE, AM, EHI conference, you can see that for those patients, if you have consumer identified like by your smartphone or by all the recording device on you, you can see those patients coming to you with the first recorded HP. You should consider them as a kind of potential patient atrial fibrillation. Maybe they are paroxysmal, maybe they are persistent, maybe they are only early fibrillation. So in this patient, they should go to more detailed evaluation, making 5 or 7 days of continuous ECG monitoring to see if there is it's been really coated. It's a significant long time. And those patients, sometimes you will take those patients with high risk group. They suggest that those patients more than 75 years old or more than 75, but also with resistant heart failure, diabetes, hypertension, stroke, or myocardial infarction, or those patients with high EMP, or those patients with a lot of alert from the wearable devices. These patients also come into your clinic and to see they can verify it by the continuous ECG. If we can recognize it and verify it as early atrial fibrillation, then you can start your treatment of these patients. So for these patients, actually we noticed that the situation that we have been changing in our concept when you're managing these patients first time atrial fibrillation. And this is a very important issue for clinical cardiologists. And as a cardiologist, when you see the patient for the first time and show you the atrial fibrillation lead, you should go on to try to manage the patient starting with the rhythm control. Of course, you have to treat the patient with anticoagulation to avoid this systemic embolism, or you can treat the cardiovascular risk factor as a complicating factor so that we can control the underlying heart disease, so that we can have the background be controlled, and also with rhythm control theory, we can reduce exercise burden. It's the most important thing that we have seen from the ECM. We have a lot of technique to do a cath separation. Cath separation is, of course, the very important part of the rhythm control, especially those patients with very frequent high loading paroxysmal fibrillation or with persistent fibrillation. Without cath separation, it won't be effective to control rhythm control. So we can go on to these patients, not just so passively going on to rate control only. So facing this patient, even with the clinical cardiologist, not yet officials, you should go on to switch patient or more aggressive control. And this idea, I think, is a very important part of my presentation. I want to share if this kind of concept could be more to all the parts of the Asia Pacific region, because we have a big organization, big population in this area, and hopefully we can have a more chance to share this idea to all the patients here.